Okay, this is part 2 of platelet refractoriness. I just wanted to add a few more nitty-gritty practical things to the talk that Tom Rafe just did. So I'm sure you'll encounter this. I got a request for HLA-Matched platelets. Now what? Or alternatively, I got a request for a Platelet Antibody Screen. Now what? So the 4 basic steps we're going to talk about are: number 1, calculate the CCIs. If the CCIs are bad, then do antibody testing. Then if the antibody testing is positive and you think you're dealing with immune refractoriness, then do matched platelets. Finally, continue to get CCIs for each product. This is the hard part. I even made a comedy sketch about this called Get the Damn Counts, if you're interested. So some of the things I think about are: number 1, is the platelet target sensible? Meaning, if the patient's bleeding, typically a platelet target is about 50 or 100 if it's dealing with brain bleeds, eye bleeds, CNS bleeds in general. If the patient's not bleeding, a common platelet target is about 10, sometimes 20, especially in neonates. And if the target is not sensible, then educate the clinician. Number 2, is the platelet increment already adequate, right? So 1 apheresis platelet unit will usually cause a platelet increment of about 25 to 50, very roughly speaking, of course. There's different amounts of platelets in each bag, and there's different sizes of patients, of course. And you would suspect refractoriness of any cause, right? Immune or non-immune, refractoriness of any cause if your increments are lower than this. And this is just by using your typical 5 a.m. or 6 a.m. count that you get every day, not necessarily timed specifically, as we'll see. And another thing I think about, if you call me and say somebody's asked for special platelets or they're worried about refractoriness, is what is the weight of the patient? So if the patient is approximately 100 kilograms or larger, sometimes they just need a bigger dose. And if you give them 2 units of platelets, then they will increment well enough. So we're going to calculate the CCI. You probably know this by now, but very briefly, the whole point of the CCI is so that we can compare between one patient to the next. We can normalize their size differences and the differences in the dose in each bag of platelets. So we're using the BSA as patient size, and we're using the platelet yield, or the number of platelets transfused, as the way to normalize the platelet dose. And most importantly, we generally require a 60-minute or less post-transfusion count, 60 minutes or less. And why do we care about 60 minutes or less after the platelet transfusion, right? Who cares about the timing? The reason we care about the timing is because antibodies are fast, okay? Antibodies tend to act very quickly. So this is looking at time on the x-axis and your platelet count on the y-axis. And if the pre-transfusion count is, let's say, less than 10, and then the platelet is transfused to the patient, and let's say we only get a platelet count several hours later. Let's say we get a platelet count, say 5 hours later. And in the normal circumstances, it would be high and up here. But usually in the patients we're dealing with for refractoriness, if it's low several hours later, I can't distinguish, just based on that count, I can't distinguish between this happened slowly due to non-immune causes like sepsis, and we'll get into more of these causes, or if this happened quickly due to an antibody, right? Because antibodies tend to act fast. So it doesn't really help us very much to get a platelet count several hours later, whereas if we got one, let's say an hour after the transfusion or less, then if it's low then, that's a strong signal that an antibody might be involved, right? Whereas if it's high right then, that's probably not due to an antibody, okay? CCI is very briefly the platelet count increment, right? The post minus the pre, times the body surface area in meters squared. It's usually something in the neighborhood of like 1.5 to 2 meters squared for most people. And then the number of platelets transfused, number of platelets in the bag. That usually is in the range of like 3 to 5 times 10 to the 11th. This is a gunner version of the BSA, and note the exponents after height and weight. So these are funky exponents. This is not terribly high yield to know. It's usually in the chart, and It's usually on a question that someone would ask you. So one example, let's say the increment is 24, say pre-transfusion is 10, then it goes up to 34. And let's say the BSA is 2 meters squared and the number of platelets transfused is 4 times 10 to the 11th. We very rarely see a platelet yield too much over 5, because if it ends up being 6 or higher, very often we'll just split it. We'll just split the unit into 2 units of 3 or greater. So we got the CCI, which is the increment times the BSA divided by the platelets transfused. So in this case, it would be the increment 24 times the BSA 2 divided by 4. So that'd be 48 divided by 4, which is about 12. And what I do as a rough, this is again very rough calculation, is I basically take the platelet increment, assuming it's 1 hour later or less, and then I just half it. I just divide it by 2. Because usually the BSA is somewhere in the 1.5 to 2 range, and the number of platelets transfused is somewhere in the 3 to 4 range. So 1.5 over 3 to 2 over 4 is approximately half, right? So I just say half times the platelet increment. So in this case, that rough estimate would work out to be roughly the same. And I don't recommend that for, say, a proper exam question, but it's a rough estimate. Then the question is, okay, a CCI of 12, is that adequate? What makes a good CCI? The way I think about this is a CCI of less than 5 is unambiguously bad, right? A CCI of 5 or less is a bad CCI or low CCI. And usually we think about if there are 2 consecutive CCIs that are low, that suggests immune refractoriness, and antibody testing is warranted. And then if a CCI is over 10, then that's good. It's unambiguously good. Whereas 5 to 10 is kind of a gray area. Some people say 7.5 is the cutoff. The way I think about it is 10 is good, 5 or less is bad, 5 to 10 is kind of in the middle. And this also illustrates, why do we use this CCI, right? What's the point? The point is, if we find a good CCI, then that saves us any additional workup in terms of special products or in terms of platelet antibodies. And we don't have to do quarantining of donors and platelets, as we'll see. So this is why it's critical to get a CCI, to get these damn counts, because if the counts are good, we don't have to do everything else I'm going to talk about, right? We save the patient money, we save the blood bank resources. So if immune refractoriness is not suspected, advise the primary team to consider non-immune causes, which they'll say, gee, thanks, we were already thinking of that. And also keep in mind that non-immune causes are about 2 times more common than immune causes. Nothing stops the patient from having both, non-immune and immune, of course. This you could learn on your own. Some common non-immune causes are fever, infection, even bleeding itself. In addition to just the loss of platelets, bleeding can cause some non-immune refractoriness, along with things like stem cell transplant, graft-versus-host disease, and veno-occlusive disease. And then, of course, the most common antibodies that we see are HLA antibodies that we'll talk about, class 1 HLA antibodies. And then, of course, occasionally we'll see HPA antibodies and other causes. So there are 2 basic strategies of providing platelets for immune refractory patients. One is HLA antibody testing. And then if that ends up being positive, then we could use so-called HLA-Matched platelets in many cases. And then the Platelet Antibody Screen. And if that's positive, then we could use so-called cross-match platelets. So 2 different strategies of how you can provide matched platelets to immune refractory patients. Remember that class 1 HLAs are the only antigens in the HLA world that are on platelets. There's no class 2. Therefore, we only need to do class 1 HLA antibody testing. If the patient class 1 typing, phenotyping, has not already been done, then ask the team to order that in parallel to expedite. Because as we'll see, we could use both the patient's antibody specificities and the patient's phenotyping to try to find matched platelets. So this is a little bit long slide, but hang in there, we'll get through it. So when we talk about HLA-matched platelets, there's lots to say, and this is a huge subject, but just as some highlights I think about are a good match if you have a good matched HLA-matched platelet, that will lead to a good response with a good CI in about 80% of cases. It's no guarantee, right? You could have a perfectly matched HLA platelet and a bad CCI, or the reverse, a poorly matched one and a good CCI. So it's not a one-to-one relationship. And we can also find antigen negative units, which means the patient has certain antibodies with certain specificities, and then we just find donors that lack those cognate antigen. And that leads to a good response rate in roughly 50% of the time. It's a wide range of response rates. So why would you do HLA-matched platelets versus cross-matched platelets? Well, one pro of using HLA-matched platelets is it's a little bit more predictable and rational because we detect specific antibodies, right? And we select the best available match. And we also have the additional benefit of trying to prevent formation of additional antibodies by knowing the patient's HLA phenotype and trying to match as close as possible to that. And then some cons are, well, HLA matched products are more expensive, usually a few $100s more per unit, number one. Number two, there's often a longer turnaround time compared to cross-matched platelets that we'll see. It may take several days to do the whole process of antibody testing, phenotyping, calling in a donor, collecting a donor, transporting the unit, and so on. And then due to this lead time, there's also a risk of waste, right? Because by the time you actually get the unit, you may not need it if the patient improves between the time you order it and the time you find a donor, collect them, and then you actually have it. It may take, say, 3 days, and then you needed it 3 days ago, but you didn't need it today. That's one method, is HLA matching. The other method we're going to talk about now, which is the platelet antibody screen and also the platelet cross-match. So in a platelet antibody screen, we're going to mix, just like with a red cell screen, patient plasma with test platelets. So instead of with test red cells that we saw with the typical red cell antibody screen, this we're going to use with reagent platelets. And a common way to do this is in solid phase, and a common platform that is popular uses so-called indicator cells, just like with the red cell solid phase platform. So these are AHG coded red cells, right? Anti-IgG coded red cells. So the anti-IgG is outward facing, okay? And the endpoint is red cell adherence. So don't let this confuse you, right? Many evil question writers, including myself, can try to make sure you can distinguish between red cell adherence, which is in fact the endpoint, and what you might suspect would be the endpoint, which would probably have something to do with platelets, right? You would expect, well, maybe platelet adherence or platelet agglutination or aggregation, something like that. But in fact, because the endpoint is using these indicator cells with red cells, that red cell adherence is the endpoint, just to hit you over the head with that, because you know I'm going to ask that on the rotation exam. So one particular platform is the so-called Capture-P. And so what it comes with is on the well, it has these purple antibodies that allows these freeze-dried reagent platelets that come with the kit to allows them to stick to these antibodies along the well. And then the next step is that you add patient plasma, right? And if the patient has antibodies to any of these particular antigens on these platelets, then the patient antibodies, these yellow things, will stick. These little yellow IgGs will stick on there. And then finally, you add the indicator cells, the red cells that have outward-facing IgG. That's also in the kit. And so what it will do is you have these indicator cells with outward-facing IgGs, and that will detect the FC portion of any IgG, right? So then it'll go along and say, there's an IgG, and it will stick there. So then when you see what they call like a lawn of red cells, kind of a uniform redness, that's positive. A uniform redness, a lawn of red cells is positive. If, however, the indicator cells do not see any IgGs from the patient that are attached to any of the reagent platelets, then all these indicator red cells will fall to the bottom, right? They'll all fall to the bottom, and just like in solid phase for red cells, for red cell testing, if you see one button or one clump of red cells at the bottom, that's negative, right? That's not red cell agglutination, that's all the indicator cells falling to the bottom. That's negative. bam, negative. So your indicator cells didn't see any IgG, so they fell to the bottom. So there's not a lawn of redness, but a single dot. That's negative. So just some real life photographs. These red dots are negative. All the indicator cells have fallen through. There's nothing for them to stick to. And then this uniform lawn of redness here and here, and here and here are positive because there's red cell adherence to patient IgG. So don't freak out. You don't have to learn all this, but this is just one example of the worksheet that you would see in a platelet antibody screen. And you're not going to be really presented with one of these because there's no real interpretation to do other than positive and negative, as we'll see. So, but just to give you an indication of what's happening, just so it's not a magic black box, you'll have, in this case, 12 reagent platelets that come with the kit. They're freeze-dried. And then it's known which HLA class 1 antigens are on these reagent platelets and which common HPA antigens are on here, right? And then you'll mix patient plasma with each one of these in a well. And then you'll have at the bottom a result, right? Was it a uniform lawn of redness that's positive, or did they all fall to the bottom that's negative? And so in my mind, there are only two possible results from this. Either all of these are negative, in which case you call it negative, or one or more of these is positive, in which case you just call it positive. Another way to say the same thing is this test is not validated for finding a specificity, right? It's different from HLA antibody testing, using the Luminex or something like that, and we could say, the patient has antibodies to HLA-A2 and HLA-B18, right? We can't do that with the platelet antibody screen. There's no validated process of like crossing out specificities and ruling in specificities, okay? It's either positive or it's negative. So it's either completely negative or it's positive, meaning you see a weak plus or greater in at least one well with one or more of those reagent platelets rather. It's not validated for determining specificity. And the whole point of doing this test is if it's negative, then you could stop and you don't have to quarantine a bunch of units off your shelf to do platelet cross-matching. That's the advantage of doing this first. Or if it's positive, then you do platelet cross-matching next. And how do we do that? Well, we use the same technology that we saw, something like a capture P, like a solid phase, right? But instead of using freeze-dried reagent platelets, we use a small volume of platelets from the shelf, platelets on the shelf. So we usually do something like take the segment, because it has some platelets from each unit as a source of platelets, and then it requires quarantining because, for example, let's say we had 10 units and we wanted to cross-match all 10, and let's say they weren't quarantined, right? And if some orders for platelets for other patients came in and we started giving them out, and by the end of it, we were left with just 3 units of platelets, and then we finished the cross-match and we said, you know what? Some of those platelets, 5 of those platelets that we already issued, those were the most compatible. Oops, sorry. So there is some logistical challenges to having quarantined platelets and also platelets that are separate that you can give out during this platelet cross-matching process. It only takes a couple hours, but still you're kind of down that many platelets in your inventory while you're doing it. And then basically there's not a lot of science behind this really. You just find the most compatible cross-match, right? If everything's positive but some things are weakly positive or 1+ positive, then we'll issue those. If some are actually cross-match compatible, we'll issue those preferentially. So there's, again, lots to say about platelet cross-matching, but very briefly, some highlights are that if you had an incompatible cross-match, you would have an inadequate or bad CCI about 90% of the time. So it's a pretty good predictor. If you had a compatible cross-match, you would have a good or adequate CCI also about 90% of the time. And we're talking about, of course, in a patient that's immune refractory only, right? Kind of a clean-cut textbook case. Some advantages to doing the platelet cross-match is that you could do it as a kit in the blood bank, and the blood bank can be the gatekeeper of it. They could apply some sort of order to this whole process, as opposed to if the HLA lab was the only lab that was involved with antibody testing for platelet refractoriness. You can imagine the clinicians could order that without even contacting the blood bank, and they may not even have had those CCIs. They may not even have had the post-transfusion platelet counts that were timed 60 minutes or less. So that could be chaotic. One advantage is it's almost always done the same day. So within a few hours from the time you have the sample, you could have products for that patient that are cross-matched, as opposed to HLA-Matched, which may take days. So that could take days, and you may also see a higher likelihood of compatible donors if you do cross-matching. Oddly enough, the HLA match grade doesn't strongly affect the predictive capability of a platelet cross-match. They have some degree of overlap, but they're two very different animals. And a donor, another way to say this is that a donor with a poor HLA match grade may actually end up being platelet cross-match compatible. So that might be worth a try. Some cons are that this may require repeated cross-matches, since your platelet shelf life is only 5 days. So everything that you've cross-matched today can't be around in 6 days. So you have to keep repeating this if the patient continues to be immune refractory and keeps needing platelets. The last step, no matter which of those two strategies you use, the last step is we need follow-up CCIs to assess the response and potentially reuse the same donors. So I like flowcharts and algorithms and such. So if we were to use the HLA-matched strategy, we start with, okay, what is the CCI? So we need the 1 hour or less post-transfusion counts. If that is less than 5 twice, then we're going to do some class 1 HLA antibody testing. And we'll also throw in the class 1 phenotyping if it has not already been done. In many cases, it's already been done because most of the time these patients are bone marrow transplant patients. So they already have an HLA phenotype. Whereas if we do 1 hour CCIs and they're not low, then we don't need to do antibody testing. So then we've done our HLA antibody testing in that case, and if it's negative, then we don't need to do HLA-matched platelets. If, however, it's positive, and there's some nuance to this, like there's a threshold to what is considered positive, which we'll get into in more detail when you have real cases. But if it's sufficiently positive, then we'll do HLA-matched platelets, but we'll of course continue to obtain the 1 hour post-transfusion count and the CCIs. And of course, we'll talk about the other considerations with the clinical team, like is their target sensible or is it feasible? And also, what is the patient's size? Things like that. And on the other hand, if we were to use the platelet antibody screen and platelet crossmatch, that method just kind of starts and ends the same, but in the middle is different. We look at the CCIs. If they're okay, we don't need to do further testing, at least from the blood bank special products point of view. If they're bad CCIs, we'll do the platelet antibody screen. If that turns out to be negative, then we don't continue. We don't have to do the crossmatch. We don't have to quarantine platelets. And if the platelet antibody screen is positive, then we'll do all those cross matches. We'll find the best available, the most compatible, in quotes, platelets to give. And of course, with each transfusion, we still want a CCI for each of those to see should we reuse donors or not. And finally, of course, we'll keep in mind the same considerations we already talked about. So I should also mention this concept of platelet futility, which again is a comedy sketch, but to say it more rigorously, if you think about, if you have a patient who's refractory or potentially refractory, and you give them more and more platelets with more and more foreign antigens, right, then you have a risk of more platelet antibodies and a risk also of a platelet shortage, right? The blood bank might run out of platelets or might have to start rationing platelets, and that might affect many patients, including that patient that we're trying to treat. So in summary, number one, the first step is assess platelet counts. We've got to have that 1 hour or less count post-transfusion. What is the patient size? If it's a big patient, like over 100 kilograms, give them 2 units of platelets, right? They're a bigger person, they need more of them. Calculate the CCIs. If 2 CCIs are low, meaning less than 5, as an unambiguous low CCI, then let's do antibody testing. And that could be done either via HLA antibodies or the Platelet Antibody Screen. And if your method of testing is positive, then we could say there's an immune component to the refractoriness, and we could use matched platelets, again, via one of those two broad methods. And as always, continue to get CCIs to assess each donor. And then this is what they call the Freddie Mercury cat. This is true, I didn't make this up. The Freddie Mercury cat, it kind of reminds me of, you know, the stance he had like at the end of We Are the Champions or Radio Gaga, something really victorious and really, you know, joyful. So I thought it was cute, and I thought it was a nice way to end. And be sure to do the quiz questions to make sure that you have learned something.